indeed is a combined presentation of a video and some data on pT1b tumors. So the first one is covering our percutaneous approach for cryoablation in small renal masses, which we do in close cooperation with our interventional radiologists. These are my disclosures here. And there's no soundtrack to this video, that's why I'm going to comment it here. That's a 62-year-old patient that underwent a partial nephrectomy for this tumor you see here in close vicinity with a cyst. And you will see here the pathology. It was a papillary renal cell cancer, type 1, low grade, 22 millimeters, and he had a regular follow-up for 5 years that did not show any local relapse. And then 5 years after the partial nephrectomy, he developed a local relapse at the lower pole of the kidney. You see, excuse me, that was not the right. Sorry. So just start over again. Just make sure that I don't push the wrong button. So that was a lesion here. And the pathology results. Is the video running? Yeah, here we are. Sorry. So here now, 5 years later, he had this lesion here at the lower pole. Shows up here. And we did a biopsy, and it was another papillary renal cell cancer. Grade 2. Question is, of course, de novo or local recurrence. Anyhow, the patient was going for focal cryoablation. We do this in a dedicated interventional radiology suite under CT guidance. And we have a wall-mounted argon supply, which is definitely easier to handle than if you need to wheel in all the argon tanks for the procedure. And the procedure starts with the planning, of course. You have here the axial section, you have here the coronal section, and you can use whatever sections might be convenient for you. And in this specific case, we aimed for a 4-needle approach, 2 needles coming rather from a posterior direction, and then 2 needles coming from a flank direction between the ribs. And with the software that we have available, of course, the 3D navigation, you can nicely plan the position of the needles and then perform the position. And we do that under conscious sedation, prone position, steel draping. As you saw beforehand, we need to test the needles if they work correctly, the freezing and the thawing. We're actually using the Galil system for this. And now we start with the needle placement. That is, of course, the essential part of the entire procedure. But with the CT, you can control for it and you can test for it. And the laser also indicates you where you should put your needle and which direction the needle should be placed. And you start with the placement here. You see the needle. And you have the different planes also here on the left screen that is not visible here. The axial sections, sometimes also oblique sections. And you can push forward the needle a little bit, check where you are, push a little bit further, check where you are, and you start now here being at the tip of the lesion. That is the first posterior one, that is the second posterior one. Once the first needle is in place, of course, it's easier. You just need to follow this track in a parallel fashion, 1.5 centimeters apart. And still you can check with every advancement with the CT if you're in place, if you're going the right direction. Still 3-4 centimeters short. Still some centimeters to go. No, actually away here, right at the tip of the lesion. And then we go there for the flank needles. First one already in place, the second one goes in there right afterwards. See it coming here. And now you see here on the oblique pictures that indeed there's a nice distribution of the needles in the lesion that is down here, and you can control in all different sections where you are positioned, and it gives you then a nice coverage of the lesion that you would like to treat. And then we get started with the final ablation. Again, we have the Galil system for needles. We are using 2 freezing and thawing cycles, 10 minutes each. Set up the system for kidney ablation. You start, then you have here at the same time the temperature control. And then we have the advantage that we can cool all needles at the same time because we have a 3D control of the ice ball with the CT, so we do not need to take care of what the ultrasound might see or might not see. And you will now here slightly see the formation of the ice ball around the needles. And actually what you see is the border of 0 degrees where the tissue is frozen, and you can identify this as a hypo signal on CT. In a few seconds you will see here the ice ball forming. You see it starts around here, starts around here. So you have a real-time quality control that you ablate the area that you would like to ablate. See it here forming now quite nicely. You see also we're also always using a very small picture or very small window to check, so the irradiation remains limited, and you see here now nicely the ice ball at the maximal extent. Again, you can quality check that you ablate the area that you would like to ablate. And then at the very end you have again the quality, the temperature control, and you can do at the end if you need some active thawing to get the needles out. You will see that in a second. Let's then take the needles out. The procedure is done. What you have at the end are 4 punctures and nothing more. The treatment is recommended, at least if you look at the EU guidelines, for small renal masses in comorbid patients or older patients. And the question we frequently ask ourselves is that also an option for larger tumors. And this is why I would like to share with you our experience with pT1b tumors. So we had 23 patients that had a tumor size between 4 and 7 centimeters. They had older age as expected because we offered these to those patients who were not really fit for surgery, or where we thought maybe active surveillance is not the right choice, maybe surgery is too much. The mean diameter was 46 millimeters, and the mean renal score was at 8, also suggesting that the surgery might not be the easiest one to do in this patient, in these older patients. The median stay was 1 day, and the mean follow-up was rather short of 14 months. It's definitely a limitation of this series. It was, as you saw, a percutaneous approach with CT guidance under sedation of the patient. The mean number of needles was 5 because of the higher volume that we needed to treat here. We used contrast media in 3/4 of the patient in order to identify the lesion nicely and to know exactly where we needed to treat and where we should not treat. We used hydrodissection 1/3 of the patient, meaning that we pushed the colon, for example, further away if ever we needed to treat some anterior lesions. And as I told you already, we had a double freezing and thawing cycles in all patients. And the follow-up was done with MR in the first year with an MR at 1, 3, 6, and 12 months, and then further on with a CT, also including a chest CT. So these are the outcomes. The primary technique failure, the primary technique success was observed in 83%, which means that in 83% at 3 months there was no contrast media uptake in the area that we ablated. And the secondary technique success were those patients that showed an uptake after the first treatment was 96%. There was one patient that had a first technical failure where we actually were unable at the first session to ablate the lesion because of poor needle placement, and all the others that we retreated actually were successfully treated. treated. We have a progression-free survival at 1 year and 2 years of 82%, but this is actually only a few patients at risk at 2 years. If you look at the data, it's a little bit slower or lower what you expect from a normal treatment of small renal masses, so definitely it is less effective in these larger tumors, but still I think 80% success rate is quite promising. We had a few minor complications, hematuria, hematoma, and anesthesiologist problems, but no major complications. And then probably what you're also interested in are the changes in the estimated GFR. In all patients, we had a drop of 4 milliliters per minute before and after the treatment. In a single kidney, we had a lower drop in there, and then probably the patient that has central tumors, we had a higher drop of 15 milliliters per minute, probably because we blessed more tissue here with the central ablation, but it's also feasible, obviously, with an acceptable functional result. In summary, we can say that cryoablation in larger tumors is feasible. It is associated to a higher rate of retreatment and recurrence, but still the results remain acceptable. And I think at least for the French conditions, you need to wonder if it is cost effective. The needle costs more than 1,000 euros. So if you put 5 needles in there, then you have 5,000 euros budget only for the needles. And there's no reimbursement for it. So you need to think how you can finance and offer this to your patients because it's quite expensive. And I thank you very much for your attention. Any questions?
Do we have any questions from the audience?
To ask that question,
Thank you.
do you use the technology to heat your tracks when you pull the needles out? The Galil machine allows you to heat the track to 100 degrees Celsius so that you can cauterize the track?
We have that option to heat it indeed. We do not systematically do it to sterilize the track, like for spillage or something. It's more like to release the needles and get them out without any risk of pulling at the tissue.
It seems to be associated with reduced postoperative bleeding or post-procedural bleeding, but you didn't really have any, so I'm not sure it makes any difference.
And we did not use any adjunct procedures like embolization or something, so actually it is quite feasible with this approach alone.
The case you presented, the mass was very close to the renal. How do you control them to avoid the damage?
We did not do any prophylactic stenting, for example, for those patients where the lesion was close to the collecting system. We have that as an option if ever there are complications afterwards, but we have the impression that cryo on the collective system is not that aggressive as it might be for radiofrequency, for example, where you get more problems with the collective system than with cryo. But that's our experience, and we did not have any problems despite the fact we were treating also central tumors with the contact to the collecting system.
Is there a concern with the collecting system if you perforate the collecting system with a needle rather than freeze into it for like a fistula, or that's not really a concern?
I'm not really aware of that. That might be a difference. You want to make sure that the needles are placed in the right way. Of course, you would like to stay away with the major vessels, so you would not like to puncture these, of course. And if they go close to the vessels, then you would avoid the collecting system, at least at the periphery, probably not to the pelvis. But if you're on the periphery, probably they're not really an issue, and you might go even with a needle inside of the collecting system without major problems afterwards, apart from a hematuria maybe, but no, not more problems than this actually.
As being the only guy that probably is dumb enough to publish this on this, we found that with the larger probes, you can actually, if you puncture the collecting system, it increases your risk of having fistulas because you have that dead tissue and then you have a breach in it, so it's not going to scar down, so it increases your probability of leaking. No, I applaud you. That was an amazing cryo case. Like, honestly, the technique and the skill to do that is few and far between, to put that many probes in different angles. It's a great case to show that you can do it, and I applaud you.
Thank you.
Thank you so much.
Thank you.